Namaskar and good evening. Welcome to this ISO webinar series 12. My name is Dr. Hemant Malhotra, for those of you who don't know me. And I am the current president of the Indian Society of Oncology. I just took over earlier this month at the annual conference in Jaipur. And it is my pleasure and privilege to welcome you to this 12th webinar of the Indian Society of Oncology. And this time we have kept a hardcore hematology topic because our organization, our society is a multidisciplinary society in which we have medical oncologists, hematologists, radiation oncologists, surgical oncologists, cancer researchers, nuclear medicine experts, palliative care experts, and we will try and cover one by one uh, topics and subjects of direct interest to each one of these specialties. And this time we are going to focus on our medical oncologists and hematologists, and we are going to cover some aspects of chronic myeloid leukemia. The way we've planned it is that we will have a welcome address by one of our very senior members, Dr. Narayan Kuti Warrior, who is the head of the institute, very fine cancer institute, MVR Cancer Center at Calicut. Then we will have an interview. I have some interest in CML, and my very dear friend, Dr. Purvesh Parikh, he's going to ask me some questions, and I do not know what he's going to ask me. And then we will have a talk by our international faculty, Dr. Jane Apperly, she's just superannuated. So she was the chief of the hematology department at the famous Hammersmith Hospital in London, at the same hospital where John Goldman used to work. She's going to tell us what is new in ELN in 2025. And then we'll have a panel discussion, which is going to be moderated by Dr. Pankaj Malhotra, who's professor and head of clinical hematology and medical oncology at the famous PGI, Chandigarh. Pankaj is one person who I've known for more than 3 decades, and an incredible leader, super mentor, and somebody who's done really lots and lots of work in the field of chronic myeloid leukemia. So, ladies and gentlemen, with this brief intro, I'm going to hand over proceedings to Dr. Narayan Kuti Warrior, who will lay the background of today's program, today's virtual multidisciplinary joint clinic on chronic myeloid leukemia. Over to you, Dr. Warrior.
Yeah, thank you, Professor Malhotra. Welcome to ISO webinar series. This is the 12th series. I must congratulate Samir and Sumant and all my executive members for the smooth conduct of this webinar series. This is something which all our postgraduates are looking forward to attend. So a very warm welcome to everyone joining us for the ISO webinar series dedicated to the critical advancement in chronic myeloid leukemia management. My name is Dr. Narayan Gutivarya, and I've been already introduced. I'm the one of the executive members of Indian Society of Oncology. And I am delighted to welcome you all to this session, which brings together leading experts from India and UK. As you know, the therapeutic landscape of chronic myeloid leukemia is defined by continuous evolution, driven by new data on existing and emerging TKIs, and growing emphasis on personalized patient care. The challenge now is not just achieving a good response, but optimizing the entire treatment journey, balancing efficacy, long-term safety, and the potential for treatment-free remission. The cornerstone of today's discussion is a highly anticipated update, the ELN 2025 CML guidelines. We will explore how these new recommendations will reshape our clinical practice, particularly regarding response milestones, TKI selection, dose optimization to manage toxicities, and the criteria for treatment discontinuation. We are honored to have such an esteemed panel of faculty with us evening, including Dr. Jane Apperley from London, who will deliver the session on the pivotal changes in the ELN 2025 CML guidelines. Professor Hemant Malhotra and Dr. Purvish will be having a discussion on certain clinically important points. And finally, our moderator, Dr. Pankaj Malhotra, will be leading a distinguished panel of experts from across India for a comprehensive discussion on CML management. I request all the participants to submit your questions in the chat box during the panel discussion, so that we can take up all the questions one by one, and especially any the questions. This is a golden opportunity for you people to have a one-to-one interaction with all the expert speakers like Dr. Jay Napoli. So, thank you once again for joining us to explore this vital updates. Let us begin this engaging and informative session. Over to you, Dr. Purvish Parik and Dr. Malhotra.
Thank you very much, Naran Kuti Warrior. It's a privilege to be here. And Hemant, with your permission, I will try and pick your brains to see what we are doing about chronic myeloid leukemia.
So
As when
thanks to
you
you. I hope you find something to pick over there. Please go ahead.
right, right. So when we were entering oncology, uh, CML was a disease of people who were in the prime of life, and they had a median survival of 4.5 years. Today, majority of patients with CML die of some other disease. So I will not dwell into that. But what is really important and what is fascinating and which will help the audience is your role in ICML. You have done a lot of work in CML, not only in India, in the clinical side, in the lab side, but also have made a name and fame at the international platform. So I would like you to start by sharing your experience with ICML.
So that's a kind of a difficult journey to make. I remember my interest in CML was awakened when Dr. John Goldman used to come to India and deliver lectures on CML. And I have no hesitation in saying that Dr. John Goldman was my mentor in the CML field. And he sparked that little bit of interest for me. And then we had lots of patients, and somehow I slowly graduated to, kind of some special interest in CML. We started a leukemia lymphoma clinic at the Birla Cancer Center of the SMS Hospital, where
Right.
I worked for 35 years. Then I started to attend CML meetings. I remember the first meeting I attended was in Chicago. So we had a full hall of people, and during the question answer session in one of the very keynote lectures, I stood up and made my comments on the number of patients which we have and the special problems which we face. And then that kind of after the lecture finished, a lot of top experts came and met me, and they were very interested in how we approach CML in low middle income countries. And one thing led to the other. And when you convey your interest, genuine interest in a field, then kind of tend to get noticed. And low middle income countries, you and me, we represent almost 20 to 30% of the world population of CML, if not
Right.
more. Some people say that it is 40, 50%. And if we say something that these are our problems which need to be addressed also, in addition to the problems in the high income countries, then people, get up and listen because we have the numbers over here. And my advice to the young oncologists and the hematologist is that if you can find a area of interest and focus on that area of interest, go to international meetings and national meetings related to that area of interest, then slowly you will find a niche for yourself. You will make a name for yourself at the national level, and you can make a name for yourself at the international level. But of course, you have to put in some hard work, some blood and sweat, and of course, make significant publications, and then you get, kind of, well, you're on your way, you're on the road to being an expert in that field.
Right.
So something like that, happened to me. Was very lucky and fortunate to witness the transformation in CML, which you were talking about, in the early 2000s when Gleevec, or STI 571, as it used to be called in that time when it made its appearance. When you had patients who were, destined to die in a few weeks' time, suddenly get up from the bed, start walking, and that miracle we were lucky enough to witness. You must have also
So true.
witnessed. Not too many of us are around who witnessed that miracle, but we were witness to that magic bullet, which became available to us, and then after one after the other, the advances happened. I remember a ASH meeting at that time on this STI 571 or Gleevec, which Novartis had just launched. And the first trial, the IRIS trial, was being presented. It was a jam-packed hall at ASH.
Yes.
Uh,
Yes.
so, so I remember those days very distinctly, and like lucky and fortunate that we could see that miracle happen in front of our eyes. Our patients start to benefit. And then again, very thankful to God and to so many mentors that they, kind of encouraged me and recognized me, and they chose me to be the national representative in the International CML Foundation. And then since last year, I'm one of the members of the board of the ICMLF. And whatever little, I think one of my uh, uh, small contributions to CML and to our country has been to be a part of the ELN guidelines, which was spearheaded by Dr. Jane Apperley, who's going to be our international speaker today. And present the situation in low middle income countries, and have the guidelines also address the vast majority of CMLs in low middle income countries. Thank you.
Right. So that's great. We will not discuss ELN because Jane is going to focus on that right now, very shortly. And you mentioned that you need to junior needs to focus on doing hard work in the subject and also publishing. But achieving international leadership status is not easy, and it is not simply based on academics and publications. There are so many other skills, soft skills, and networking that is required. So, do you have any such hints for our juniors who have now a greater competition? You and I started when there were only a handful of oncologists and hematologists. Now, more than 200 are, getting their degrees every year. So, what is it that you can give as a mentor? What special hints you can give them?
So if you want to make a mark at the national level or the international level, then again you have to choose a subspecialty or a subspecialty, develop some extra expertise in that, start to collect cases in that, and start to communicate either by virtual methods or by physical methods during conferences with the key opinion leaders. These key opinion leaders could be in nationally in India, or these key opinion leaders could be in the international forum, and kind of get noticed first of all. And once that happens, the higher you go up in the field, the more humble and approachable you became. So that is what I have observed. I know all the CML leaders in the world by first name basis, and they're such wonderful people. And I'm certainly including Jane in that, that you can just go up to them and talk to them and, call them to your country. They're happy to help you, So identify a subspecialty area of interest, work in that area of interest, make your presence felt at national, international meetings, choose two or three mentors. I was lucky enough that I chose John and John chose me. So, and then, then slowly the process happens. Of course, you have to be lucky also, and of course you have to be you have to be good. I don't want to kind of praise myself, but persistent effort that does make you noticed and does help you slowly climb the ladder to recognition in that particular field.
So, doing hard work that makes you get noticed. And then, like you rightly said, a mentor chooses you. And that I think is a kickstart. Today, there is a lot of availability of social media. Would you advise the juniors to take advantage of social media? And if yes, in what way?
So I'm actually not the right person to ask that, because I am pretty illiterate in this social media business, because it started way after my time. Trying to catch up, I ask my son to help me all the
Fair enough.
time, and most of the times he has his own nakhras to say. But you might be the better person to answer that, and I think. A social media presence, say on Facebook, on LinkedIn, on Instagram, is absolutely essential and mandatory today, because
Right.
that is where the young people are. That is where the young people are going, and not only young professionals, but also patients. They are getting their information, and a large chunk of their information from these platforms. And whether you like it or you don't like it, you have to have a presence over there.
Right.
If you are not literate, like I am not literate in these things, then you have to seek help, and
Fair enough.
learn quickly. But there is no avoiding not
Yeah.
being in social media platforms in today's time.
So easy accessibility of information to patients. Often the patient comes with reams and reams of feedback from Dr. Google first, and now all the artificial intelligence tools like ChatGPT. When you face such a patient, how do you deal with them?
So that's a tough one, and that is uncomfortably becoming more and more frequent now. Like the way I deal with it is, suppose there is a conflict of recommendation from, as you say, Dr. Google, and what I feel. So I, kind of tell the patient that I'm aware of the literature which you have searched, and I'm aware of the literature on the basis of which this internet recommendation is based. But considering the ground realities and the whole milieu of your disease and your other issues, this is what my recommendation is.
Fair enough. Fair enough.
So, like, you have to be candid and upfront, and of course, you have to be updated on where the information the internet is coming from. If there is a phase three study recently published, if there is a FDA approval of a new drug, then you have to be aware of that. So, I think it is one of the ways which keeps you on your toes also with regards to knowledge.
Right. So coming to the current status, there are at least 6 approved BCR-able TKI inhibitors. But let's start with the STI that you mentioned, imatinib. Uh, Generic imatinib has made life so much easier for our patients, both in terms of accessibility and affordability. Do you think that the generic imatinibs that are available to us are providing the same results as you would find with the innovator molecule, or there is a difference?
So I think there are some very fine Indian generic imatinib manufacturers,
Right,
and the product from those standard Indian generic manufacturers is as good or as bad as the innovator product. And there is science to this. There have been publications, at least from four centers. We have published in the leukemia lymphoma. Dr. Pankaj has published a direct head-to-head comparison between one standard Indian generic and Gleevec. There has been one publication from Dr. Lalit Kumar's group in All India Institute and one publication from Tata Hospital in which the blood level work has been done comparing generic to innovator, and it is very comparable.
Okay.
And we have, each one of us has hundreds of patients who have received standard Indian generic imatinib and has had complete hematological responses and deep molecular responses, even TFR. So the pattern of response is exactly the same as the innovator. All of us have a handle on the responses produced by the innovator also because of the GPAP program. And I can
Yes.
very confidently say that some Indian standard generic manufacturers are as good as the innovator, no doubt in my mind at all.
Fantastic. So for the juniors, the take-home message is that good companies, innovator, generic, and good companies, Indian imatinibs are identical and can be used easily. Earlier, bone marrow transplant had a very, very important role in potentially curing patients. Do you think that allogenic bone marrow transplant still has some role in CML?
Absolutely, there is a small population of patients in CML who will be cured or can be cured by allogenic bone marrow transplantation. Number is much less now, and it has now been relegated to maybe third line or fourth line. But that hardcore group, which is multi-resistant, the T315I patients with accelerated phase with blastic phase CML, the only way you can cure them is to take them to a transplant. Of course, you have to get their disease under control and that bridging therapy, the
Right.
point where they get to the transplant. We have several options there now to get them to the bridging. But there is a small number of patients, and it is relegated to third, fourth line, but it remains a curative option of treatment for a significant number of patients of CML.
Today, when you see a patient of CML and start treating, the interest is to have a deeper remission and more rapid remission. And that is all based on molecular testing. You want to know the MDR level at log 4 and 4.5. Do you have difficulty? I know that you already have access to a very fine international standard lab for yourself. But as a country in India, what is it that we are concerned about as far as this testing is concerned?
So I think the first thing is the transportation issues,
Yes,
the room temperature or the shade temperature in our country, in many parts of our country, in the peak of summer can go up to 35, sometimes 40 degrees. So the transportation is an issue, like the sample has to be collected properly, the sample has to be transported properly, and it has to reach the lab in a finite period of time. And then the lab has to have quality control procedures and SOPs in place. And it depends on the clinician to choose a lab which has all these things in place and where you can ensure that the collection of the sample by the lab personnel and the transport is optimal. And then the lab has to be, if possible, an accredited lab and giving you a report on international standards using the conversion factor, using adequate number of control gene copies, particularly when you're talking about low BCR-able levels. So it depends on the clinician, and it is the clinician's responsibility to choose a lab which provides all these things to you. And
right.
fortunately, there are several labs now. Obviously, we will not list those labs in this particular CMA, but there are several labs which qualify and which are doing a good job of giving us a high quality
Yes,
RQ-PCR,
yes.
BCR-able report.
So there are several academic and several commercial labs that we can totally rely on in following up our patients. And
Very
the
true, sir.
real reason why we have to do that is because we start with the RNA, not the DNA. And RNA is a very fragile molecule, and that is why all these concerns exist. Now the world over, and Pankaj is here, so Pankaj has also got the experience of treatment-free remission, and I think that is what is going to be the biggest challenge for India as we move forward. Patients are first of all become complacent. Their dose intensity goes down. If they have the slightest of side effects, they will stop that. Sometimes they don't even tell their doctors what they are doing. So how should we approach the treatment-free remission? And I know that you have very strong views about how we should move forward in India.
So I think I really truly believe that treatment-free remission should be the goal for most patients of CML. Whether you succeed in doing it or not is another issue, but it should be the goal for most patients with CML, particularly the younger patients, because you don't want your CML patient to be exposed to a TKI and if you can call it that, a dirty TKI, meaning that in addition to inhibiting the BCR-ABL, it inhibits several other cell processes. And we don't know 10 years of exposure or 15 years of exposure or 20 years of exposure, what long-term toxicity that is going to produce. But I also believe that the guidelines for TFR in low middle income countries should be a little more conservative as compared to the guidelines which are published from data from the West. And this is, my belief is probably stems from the fact that our patients come to us with really massive disease and very huge tumor loads. And then it takes all that much more time to get this tumor under control. And I also believe that we are picking up our patients of CML later in the chronic phase when there is a lot more genomic instability and a lot more, below the surface mutations happening. And that is one of the reasons why we have a slightly poorer hematological responses and molecular responses. So my true belief is that the guidelines for TFR in our country should be a little more stringent and a little more conservative as compared to guidelines from the West. And I think there are guidelines from Argentina which also reflect the same. And it is my really fond wish and hope that CML leaders like Pankaj and Dr. Warrior and yourself will join me in setting up a consortium where we can look at data available from India and look at writing guidelines. That project is there in my mind. And then very soon in the near future, I'll come back to you and maybe we can do that and have some India specific and low middle income country specific guidelines for TFR in our region. Thank you.
But if you look at I'm just trying to flip the coin. India is like 10 European countries, right? And we have a vast spectrum from the underprivileged to the privileged. And today, with the modern ways of investigation, about half CML patients are diagnosed incidentally because they went for a medical fitness test. So, do you think that your conservative approach to guidelines would be only for those who are having a larger disease burden, and not for the people who are incidentally diagnosed or who are in the middle upper class and who can do all the things that are necessary, like in the Western world?
So I think this spectrum of patients exists all over the world,
Right.
and like from less privileged to the very privileged, the balance might be different. Like there might be more less privileged patients in low middle income countries as compared to privileged, and this balance might be, say, different in Dr. Jane Apperly's country in the UK. And all the TKIs, first generation, second generation, are provided by the NHS in England. So all those factors need to be considered. And when
Fair
you
enough.
make a guideline, you make a guideline for everybody clubbed together so that there is the greatest good of the greatest number. And I think that is what we should do in our country also. That if you and your guidelines say that minimum exposure to first generation TKI should be 8 years, then that'll be just a guideline, and then the clinician, the expert who is going to look at those guidelines and maybe follow those guidelines, he
I
will
hear you.
individualize this to his or
All
her
right.
patient.
So the last 2 points I have. One is that there is a new drug which is completed phase one and phase two. It is a molecule from Sun Pharma, which is the Indian molecule. And you have the likes of Tapan Saikia and Sashikant Apte and Krishna Kumar Ratnam and Naveen Khatri as co-authors, and that is vodobatinib. Do you have any projections, forward-looking statement as to would this be useful, not useful?
So I think the phase one, phase two data in the publication is quite exciting, and we are really looking forward. They found out the dose of avobatinib to go forward in phase three studies, and
Right,
we're really looking forward to avobatinib going forward in the phase three. And hopefully, we will have an Indian molecule which will provide another alternative to a subset of patients of CML. And
right,
hopefully, because it's an Indian molecule, it will be less expensive and more accessible to a larger majority of our patients.
right. So as they say in India, aapke muh mein ghee shakkar, that we get the right answer from that.
Yeah,
My last question is about the new exciting class of molecules called BCR-able degraders or the protect-based degraders.
yeah.
What is your thoughts on them?
So I think again that is an area which is producing some excitement in the CML front. After the STAMP inhibitors, asciminib and asciminib-like molecules, and there are now three or four molecules which are in advanced phase three, the STAMP inhibitors. This is the next advance which is happening in CML. But it is early data and preliminary data, but the concept is there, and the thought process is there, and the phase one, two are for several molecules are in place. And I'm quite sure that one of these molecules will make it into phase three and will be available to us for third line, fourth line, maybe fifth line treatment, particularly for patients who fail the allogeneic transplant also. So, like people thought that once the TKIs were there, CML was done and dusted. But that is not the case. A lot of patients still need some innovation and some advances to happen, and that is slowly, gradually happening. New molecules are being discovered. New molecules are finding a niche in the treatment of CML, and the stamp inhibitors and the asciminib is one prime example. It is available to us in our country also now. And this new group of protect inhibitors, this also, I'm sure, in over a period of time, will establish their role in CML and will be an added weapon in our armamentarium against the disease.
Perfect. I think you summed it up real well. I had a couple of questions on pediatric CML as well, but I think we've run out of time. So I will, stop here. And I thank you once more for, sharing your global and international experience with the Indian colleagues. And I'm sure that many of the youngsters will be, calling you to take your advice and follow your footsteps in this field of CML. Thank you very much, Hemant.
Thank you. Privileged for this opportunity. Thank you, sir. Dr. Warrior, are you going to take over or do you want me to continue? Sumant, you want to take over?
Sir, you can continue.
Okay. All right. So, ladies and gentlemen, after that, small chat with Dr. Parekh, my very dear friend, and I hope it wasn't too boring for you. it is my pleasure and privilege to invite our international speaker, Professor Jane Apperly. Jane is one of the world leaders on the CML front. She is one of the directors of the International Chronic Myeloid Leukemia Foundation. She is a very dear friend and a mentor to me. I remember I did one preceptorship program of 8 weeks at her hospital, and it was like such a massive learning experience. I have very fond memories of those 8 weeks at Hammersmith with Jane and her team. And she is also the first author of the ELN 2025 CML guidelines, and there cannot be anybody better than Jane talk to us about what is new in the CML 2025 ELN guidelines. And I think there she is. I can see her. Finally, she switched her video on. So, Jane, thank you very much for being there. I hope the weather in England is not too cold. And we look forward to your talk, and over to you.
Thank you very much indeed. The weather in England is very cold, so I'm very happy to be sitting inside talking to you today. I thought you were going to say that there was nobody better than me to teach you how to reach a compromise, which is my all-abiding lesson from trying to guide the recent ELN recommendations. I'm just going to share my screen if I can. Where is PowerPoint there? Try and get it to the beginning.
Yes, ma'am. Just put it full
So
screen.
your presentation has opened at slide 41. Now it is at slide 1. And if you could put it on show,
Yes.
Yeah.
we can see you and hear you, Jane. Please go ahead.
Okay, perfect. Okay. So as I said, thank you very much for asking me to join you this afternoon for me, this evening for you. It's a great pleasure to be here. And I know that I've been asked to run through the big changes in the recommendations in the next 20 minutes. So I apologize because I'll be going relatively quickly, but I'm hoping that most people who are interested in CML have managed to at least glance at the highlights of the recommendations. So these are just my disclosures. I've obviously worked for most of the companies that produce tyrosine kinase inhibitors. Not worked for, but presented for. So for those of you who are much younger and perhaps not familiar with the evolution of these guidelines, this is the 5th iteration of the European Leukemia Net recommendations. They started back in 2006 under the auspices of Michele Baccaroni. And remember in 2006 that pretty much none of us had used anything other than imatinib. Prior to this, we were used to determining the response of CML to drugs, by which I mean busulfan, interferon hydroxycarbamide, by cytogenetic responses. So we weren't so familiar with using molecular measurements, which were obviously invented really for patients post-stem cell transplant. But when I look back at those recommendations, which were really largely guesses, I am really struck by how well they've stood up over time. Now, the reason that there's 5 iterations now is that after each one is published, the group, which now consists of 38 panel members from around the world, take a look at what they've written, and about a year later, they come together and see whether they think the recommendations hold or whether there's been new evidence which might make you want to change or modify slightly what you said before. So the previous version was in fact in 2020, so 5 years have elapsed. And one of the reasons for the gap between the 4th and 5th is because we all knew that asciminib was coming and we were waiting to see how that would pan out so that we could include at least some reference to it in the guidelines. when we identify areas that we think there's been a change, we obviously want to produce a recommendation. So we develop a set of questions which are distributed around the panel, which ask for varying levels of agreement as to how strong a recommendation should be. And we want a 75% consensus. And if we don't get that, sometimes it's just because the question is badly worded, can be interpreted in several different ways. So we just try and prune the questions until we get down to something that will achieve a consensus. It's okay not to have consensus. There are many unanswered questions. And so what we do when we don't have consensus is just to discuss the subject in more detail in the text. We do a lot of stuff, of course, by email and online, but we have had face-to-face meetings, which I actually think remain incredibly productive for listening to everybody's point of view and achieving compromise. So the recommendations are divided into the following subheadings. I'm not going to go through each of these subheadings. Some of them really haven't changed since the last recommendation, but they are incorporated into the body of each version so that people don't have to go between all the versions. The first thing I wanted to address was disease classification. Now this is a controversial subject, and in fact, we did not reach consensus. And why is that? Well, I think you probably know that this has been a topic over the last 3 years because the European Leukemia Net, for which probably read MD Anderson Cancer Center, and the WHO have classifications of disease phase that are not exactly the same. And if I just show you the definition of accelerated phase, you can see they really are quite different. And patients with blasts between 20 and 29% would be blast crisis with WHO, but would just be acceleration with the ELN. And the other issue for which we were waiting for more information was whether additional chromosomal abnormalities present at diagnosis are a poor prognostic feature and would take a patient from definition of chronic phase to accelerated phase. The problem for WHO is that over the years, they have essentially in acute leukemia defined AML, ALL as blasts greater than 20%, and it didn't make sense to them that CML was very different. Is a patient with 28% blasts really somebody who can be treated simply with a tyrosine kinase inhibitor? So in 2022, the WHO reclassified CML and lost accelerated phase. So it was redefined as a biphasic disease, and blast crisis was blasts over 20%, extramedullary blasts, and the presence of lymphoblasts, irrespective of what percentage. The patient became a blast crisis, and everything else was chronic phase. Now, this is controversial. We did not reach consensus. You're at liberty to use whichever classification you like. The arguments for this change were that genetic studies originally from Jerry Radich in Seattle back in 2006 or 2007, but reproduced, suggests that CML is a biphasic disease with patients in the higher end of accelerated phase looking more like blast crisis, and in the lower end looking more like chronic phase. We all know that, first of all, patients presenting in accelerated phase these days is a relatively rare event, but usually we would just give them a TKI, and actually many of them do just as well as a patient with chronic phase. There's also some very nice studies showing patients with 20 to 30% blasts have outcomes much more similar to blast crisis than to chronic phase. So the WHO approach made sense. The prognostic impact of additional chromosomal abnormalities at diagnosis is much less clear than when they emerge on treatment. I think we would all agree with that. And WHO wanted to align with AML. The arguments against were that we shouldn't really be throwing the baby out with the bathwater. We're dismissing a long-standing and very well understood definition. Calling patient accelerated phase identifies somebody who may benefit from a more potent TKI as first-line therapy, so it has a clinical impact. There would be a problem if you wanted to do a study in accelerated phase in the future because it wouldn't exist. I have to say that it'd be very difficult to do a study in accelerated phase. It might be slightly different with patients coming to the attention of the doctor somewhere like India, but in the West, we would have to work for maybe 10 or 15 years to get a reasonable number of patients in accelerated phase. And the argument was that it would be very difficult to compare results from new studies with those based on previous classifications. Irrespective of whether you want to retain accelerated phase or whether you want to agree with WHO, there's no doubt that actually both classifications come together on the fact that there are high risk factors at diagnosis, and it doesn't really matter what you call the patient. So a patient with a high ELTS score, patients with between 10 and 20% blasts, patients with high basophil numbers in the peripheral blood, and additional chromosomal abnormalities, particularly the very nasty ones of monosomy 7, isochromosome 17q, and complex chromosomes. 3q26.2 doesn't really occur outside blast crisis, and the histopathologist would always be wary of these clusters of megakaryocytes with fibrosis. All those indicate a patient at diagnosis that you might want to use a more potent therapy early on, and if they didn't respond to that potent therapy, think about early referral for transplant. We're also aware that things that happen on treatment are also indicators of high risk for progression. So if you don't get complete hematological response on your first TKI, which is almost unheard of, but it's bad news for the patient. If you're resistant, not intolerant, but resistant to 2 sequential tyrosine kinase inhibitors, unless you developed a kinase domain mutation that renders you sensitive to another one, the emergence of new chromosomal abnormalities and the occurrence of complex mutations in the BCR-ABL gene, so compound mutations during therapy, they're all indicators that your patient is not going in the right direction and you may have to change treatment. Then if I move on to prognosis, it's been very customary to start talks on CML showing data from the Scandinavian population survey, because the Scandinavians have amazing population-based data which link pretty much all your medical care, your diagnosis, your pathology with social factors such as your job, your level of education, whether you smoke, etc. They produce amazing data on a wide range of diseases, and they showed some years ago that the life expectancy of CML on a TKI was approaching the life expectancy of an unaffected individual. So it's a wonderful story, but more recently they have produced this paper, which is, I've taken the curves from this paper, which are not that easy to understand, but obviously they're divided into men and women. And this one is the loss in life expectancy or an estimated loss of quality adjusted life expectancy. And you can see that if you are diagnosed at the age of 45, you still lose on average about 5 years of your life. I mean, it doesn't impact so much when you're 85, but the message they were trying to convey in this paper is that we are not out of the woods yet with CML. There are some patients who still have a very poor prognosis, even though it's a small proportion of people. So can we identify those patients and get them the right treatment as early as possible? So I've talked already about high ELTS score and additional chromosomal abnormalities. There have been a few things in the literature over the years that suggest other factors may be important. We debated long and hard whether the transcript type, the E13A2 versus the E14A2, had a prognostic impact, and we don't think the evidence is good enough as yet to suggest that, and we would not recommend trying to make your treatment choices based on the transcript type. The thing that's fascinating everybody now is the presence of somatic mutations in genes other than BCR-ABL1, which occur in about 20 to 30% of patients. That's a very high figure for somebody who presents in chronic phase. It's probably a lot less than that, but in blast crisis, it's very common. We felt when we submitted the publication that this was not firm enough to alter your clinical approach to a patient. We felt it's still under research. It probably has an impact on the depth of response and event-free survival. I'll show you that in a moment. But nobody as yet has been able to show that it has an impact on overall survival. And most of the studies that are done in patients with somatic mutations or not are done in what we call extreme responders. So you can show that people who do very badly are more likely to have them, and people who do very well are less likely to have them. But you don't know what happens to the mass of patients in the middle and whether that should determine what treatment you give them. Some of the studies did not confirm that the mutations were limited to the Philadelphia positive clone and may have been CHIP mutations in otherwise normal hematopoiesis. But what really swung us, I think, for not including it as a reason to change your initial management was this very nice study from the Adelaide group, which looked at the presence of somatic mutations at diagnosis in 315 patients who had received various TKIs. And you can see that the ASXL1 is red, mutations other than ASXL1 are blue, and no mutation is in black. And if you look at major molecular achievement of major molecular response, failure-free survival, and the risk of developing a kinase domain mutation, ASXL1 confers a poorer outcome. But if I then tell you that these 315 patients contained over 100 patients that were treated with asciminib at diagnosis, which we believe is our most potent drug in first line, it made absolutely no difference. So you can't say, I'm going to give the patient dasatinib because they've got an ASXL1 or even asciminib, because it's not going to impact their outcome. If we move on to monitoring response to treatment, this is where my skills at trying to achieve compromise were sorely tested, because there was a lot of debate about this. And we had to keep reminding ourselves, which I think you discussed very nicely in your conversation before, about what we're trying to achieve with a document like the recommendation paper. It's not for the person who is lucky enough to indulge themselves in seeing only patients with CML and have built an incredible expertise and can use experience as well as data to determine what you do in an individual patient. The goal is to try and keep the vast majority of patients safe and are applicable to everybody in the world, whether they have 200 patients in their clinic or whether they just see 2 patients a year. And we are trying to achieve safety. So we don't want any patient to progress to blast crisis, because you only die of CML if you progress to blast crisis. Others, of course, feel that we're trying to achieve treatment-free remission and identify patients as early as possible who may be candidates for treatment-free remission. That's perfectly true. And certainly we don't want patients anywhere in the world who don't need to be on a drug to continue being on the drug. But we had to keep reminding ourselves that our paramount goal is to keep people safe. So we have changed a couple of things in the response milestones. The measurements are still at 3, 6, and 12 months. We've changed the terminology. You'll remember it was optimal, warning, and failure. We changed it because of a body of patients who felt that we needed to get rid of the term failure because they didn't like to be told they were failing. The drug was failing, but the patient was not. So we changed the terminology to favorable, warning, and unfavorable. The criteria for favorable and warning, the PCR you would expect at the various time points, are identical. Unfavorable comes now with, instead of treatment switch essentially mandatory, with treatment switch preferred because the patient is at high risk of developing resistance. And I would say that everybody was in agreement that the best situation to be in was to make sure that you didn't have a PCR more than 1% at 12 months. But there's an argument for some patients who haven't quite achieved that level. And I would urge you, before you go away and decide that being between 1 and 10% at 12 months is okay, to read the text to see what we actually mean by that. The whole debate was prompted by a paper out of the MD Anderson 2 or 3 years ago, which looked at 130 patients who had not achieved MMR 2 years. I'll remind you that MMR has never been a criteria for failure, or lack of MMR has never been a criteria for failure, because this German CML4 study showed many years ago that it took about 2.5 years on average for people to reach MMR on imatinib. But it suggested that some patients were slow responders and that having to have a PCR less than 1% at 12 months, equivalent to complete cytogenetic response, was not incompatible with a poor, did not necessarily lead to a poor outcome. So that prompted this reanalysis of the big German CML4 study. Now, I just need to remind you that this was a huge study, almost 1,600 patients, started in 2004 when we did not have second generation drugs. And it was a randomization of different doses of imatinib with or without interferon or IOC. Those days, fortunately, are gone. But what it showed was that because we weren't obsessed with PCR at the time of the beginning of this study, they didn't have PCR results on all the patients. So at 3, 6, 12, and 24 months, they had PCR results on about half the patients, but the patients 805, 891 aren't necessarily the same patient. It's just when you happen to have a result. And the proportion of patients with more than 10% at 3, 6, and 12 months clearly is decreasing. Remember, the previous definition of unfavorable was being more than 1% at 12 months. But by the time you get to 12 months, you're only talking about 8% of patients who would be more than 10%. And actually, you can see being more than 10% is really bad news because a lot of the patients progressed and died. Now, we wanted to see what would happen if your PCR was more or less than 10% at 12 months. And this curve, which shows you that people who are more than 10% at 12 months do very badly, seemed to me to be pretty good proof that you shouldn't be more than 10% at 12 months. But of course, you may have to do something before the patient reaches 12 months, because if you leave them until 12 months, the patient is on a downward curve. So then we looked at being more or less than 1% at 12 months. Remember, being more was the previous definition of resistance. And for me, actually, these curves are separating. And it seems to me that it is important to be less than 1% at 12 months. It's not as marked as the previous curve, but they're definitely separating. But when you break this down to patients by age, on the left, you can see what happens to people who are under 60, and it goes, blue is less than 1%, so CCYR. I think it's a greenish color between 1 and 10%, and the black line or dark green line is more than 10%. You can see that if you're under 60, there is a bit of a difference between being less than 1% and 1 to 10%, but there's a big difference being over 10% at 12 months. But if you look at the over 60s, actually they're all doing badly. And the reason for them doing badly has nothing to do with CML. They're not dying of disease progression, they're dying of their comorbidities. So that led to a discussion about what you do about the older, frailer patient on imatinib who hasn't quite hit your ideal response at 12 months, but for whom switching to a second generation drug with more adverse events may not be the kindest thing that you're going to do for them. So in the end, we thought that one of the messages of this document is that you really have to start personalizing the management more than we've done in the past. First of all, you never switch TKI on the basis of one result. You always look for a trend. If the PCR is going steadily downwards, then probably the patient is doing just fine. There's lots of reasons. They may have been a bit non-adherent. They may have had to come off the drug for side effects. They may just be slow responders. But if it's going steadily downwards, they're probably doing okay. Some of the people in the previous failure category were obviously late responders, and some of them are older, frailer with comorbidities and won't necessarily benefit in their general health from a more potent drug. Others would argue that you need to stick to the original milestones, because you want to get patients with deeper responses so that you can get them to treatment-free remission. Well, there's been a couple of papers that have suggested that although that's an admirable goal, it may not actually work in practice. So the top table shows you patients' results at 3 months. So we want patients to be less than 10% at 3 months. So more than 10%, less than 10%, less than 1%. And then on the right, it shows you the proportion of patients who achieved a deep molecular response, MR4 or better, at these various time points, 2, 3, and 4 years, because that's the entry criteria for TFR. And you can see that if you were under 1% at 3 months, you've got a very, very good chance of being in DMR at 4 years. But if you were more than 10%, you've got a much less good chance of being there. So maybe your patient who's going to get to TFR is identified early on as somebody who hits the optimal milestones. And then the Germans looked back at who they had attempted treatment-free remission in. And for those who were optimal responders or favorable responders at 3, 6, and 12 months, about a quarter of them were offered the option of treatment discontinuation. But for patients who had failed those milestones, then less than 5% eventually got to DMR and offered the opportunity of discontinuation. So chasing a deeper response may also not be terribly successful. You can try, but don't keep chasing and giving the patient a more and more potent drug with more side effects if it's not actually going to happen. The other fascinating paper that I would recommend everybody reads, because nobody really understands it, is this beautiful paper on quality of life from Fabio Efficaci, who looked at the patients in the Euroski study and asked, after they stopped the drug, did any of their previous ill health improve? And you can see, if you're looking at physical functioning, so that's sort of, how well you move and get about, actually it just continues to deteriorate, irrespective of you being on or off the drug, which means all of us are just getting older. And if you look at role functioning, which is not only your physical abilities, but your ability to do your job or study or look after your family or whatever it is, it improves only in younger patients. So this is just significant of aging. But if you want TFR because you think your patient will feel better, then this paper says you might be being overly optimistic. If we move on to first-line treatment, which you've already discussed a little bit in the chat, we now know that we have 5 TKIs approved for first-line treatment, but they're not available in all countries. Asciminib, I think, will struggle to get approval in the UK because of its cost, and I suspect it might be a problem for you as well. We are very careful in the ELN not to recommend one drug over the other, because there is a right drug for a particular patient. Although you may get faster and deeper responses with more potent drugs, nobody has shown an improvement in survival, and we know they have additional adverse events. I think the Germans with the Tiger study have shown that there's no role for the addition of interferon to a TKI in first line, because although you might get slightly better molecular endpoints, it's offset by increased toxicity. And then I'm not going to go into it here, but we did discuss in quite a lot of detail whether the drugs are licensed at the right dose. And in particular, there's been a lot of debate as to whether dasatinib needs to be started at 100 milligrams or whether 50 would be fine. We have an increasing number of drugs for CML. On the top of this is the ATP competitive TKIs. Obviously, olverembatinib is not yet available worldwide, and redotinib is, I think, licensed only in Korea still. And then at the bottom, we have the myristyl pocket inhibitors. Of course, we know about asciminib, but there are 2 others coming very quickly. And in fact, the TGRX was recently published its first phase 1 results. Now, how do we deal with the fact that the first-line asciminib study, asked for first, showed that if you compared, so this was quite a complicated study, I'm sorry about this, but basically asciminib can be compared with all other TKIs, because when a center entered the study, they were asked, if your patient does not get randomized to asciminib, are you going to give them imatinib or a second generation drug? So if the center said imatinib, that left a comparison with asciminib versus imatinib. And if the center said second generation, it gave you a comparison of asciminib versus second generation. So when you see the results, there's always three groups: asciminib versus everything else, asciminib versus imatinib, and asciminib versus second generation. And you can see, if you're looking at the primary endpoint, which is MMR, at 12 months or 2 years, that asciminib in green outperforms the competitor, whether it be all TKIs or imatinib or second generation. Although I think we can all see that the difference between asciminib and the second generation is not as marked as between asciminib and imatinib, and I think that's what you'd expect. So it's probably more potent. I don't know if it's as potent as ponatinib, and probably we will never know, but it's probably more potent than the readily available second generation drugs. But the thing that seems to be its big advantage is that it seems to be better tolerated. So grade 3 adverse events occur with all of the drugs, maybe a little bit less with asciminib. Adverse events leading to discontinuation were less with asciminib, and adverse events leading to dose adjustment or interruption. So it does seem that it's going to be better tolerated, although the jury is out still on a number of things. I would, if you're going to use it, watch the blood pressure, and I still don't think we completely know about vascular occlusive events. So when you choose your first line treatment, you've got lots of drugs available. If you're lucky in your country, you look at the patient and their disease, whether they have high risk factors, whether they themselves are capable of tolerating a stronger drug, and you make your decision on personalized medicine, not including affordability and availability in your own country. What is interesting, actually, and again, this table is in the manuscript, is what you do, not necessarily in first-line treatment, of course, but when your patient develops resistance due to a kinase domain mutation. There are two mutations, M244V and F359, which is actually in the box below the red box, where asciminib is not going to work. And there's been a lot of lovely work by Oliver Hanschel from Austria showing why there is a conformational reason why asciminib can't work in what we would typically think as ATP kinase domain mutations. What is emerging is that mutations are occurring in the meristal pocket for patients who are given asciminib. And so if you have a patient on asciminib who develops one of these mutations, you need to give them a more conventional ATP competitive TKI. When you look at that list, you're quite alarmed. But if you think back to what happened when we had imatinib, and every few weeks you would open a journal and there would be another mutation reported for imatinib, I think it's probably equivalent. Treatment-free remission, obviously a goal for many patients. Just for comparison, I put up the criteria for treatment-free remission from the American NCCN, from the British Society of Hematology, and you can see that it's based on treatment duration, a level of deep response and duration of that response, and various factors like whether you've ever demonstrated resistance before. The ELN have gone into a little bit more detail, and they have defined things that are mandatory, which include a motivated patient and access to decent PCR. You had that discussion before. Minimal criteria for the patient who's desperate to stop, which is slightly less stringent for the duration of treatment and the duration of DMR than the optimal criteria. And anybody in the optimal criteria really should be offered a chance to discontinue treatment. With respect to managing a patient in treatment-free remission, there's very little difference from previous recommendations. The loss of MMR is a trigger to restart. We have become more lax about the frequency of monitoring. So instead of every 4 weeks in the first 6 months, it goes out to 6 to 8 weekly, then 2 monthly for month 6 to 12, and then 3 to 6 monthly afterwards. Obviously, all these recommendations depend on what the patient's PCR was. So if it's going up a bit, you're not going to wait 6 months for the next test. But I think we have to depend on common sense here. There is a very tiny risk of relapsing directly into blast crisis from treatment-free remission. I don't think personally this has anything to do with stopping the drug. I think we've seen this after allogeneic transplant. It can happen because the cell can remain dormant. I'm going to go quite quickly through the rest because they're all tables that I just want to draw your attention to rather than actually talk you through them. There's been a lot of new information about the safety of parenting on TKIs, and in general, we think men can continue their TKI whilst they're trying to conceive a child. The bigger problem is women, and if you're in the fortunate situation of being able to plan the pregnancy with the woman, then how you manage it, which is written in this table, depends on the level of molecular response that the woman is in at the time they want to try and become pregnant. Being eligible for TFR is obviously the best position. Not having achieved any form of molecular response is a very bad position and should be discouraged at all costs. And for those patients in MMR but not in MR4, they're a mixed bag. There are people who would get to MR4 if you left them on the drug long enough, and there are people who are just stuck in MMR. But if you stop the drug for pregnancy in MMR, your patient will almost invariably lose their MMR, but will not require treatment because they won't lose hematological remission. And then you have the more difficult situation. I think you face this probably more often in India than I do in the UK, of the patient just pitching up to the clinic and telling you they're pregnant. And again, you obviously discontinue the TKI and you would avoid it like the plague in the first trimester. I personally would avoid it for as long as possible, but could have my arm twisted in the third trimester. Others are a bit more gung-ho and would give it in the second trimester, depending on the nature of the patient, the change in their counts, etc. And again, there's recommendations for how you manage each situation. Adverse events is obviously a big issue. We have to kind of not talk about comorbidities and adverse events in the same breath because they're slightly different situations. But if you have a patient with a lot of comorbidities, then you have to be very aware of the adverse events of the drug that you're going to prescribe for them. There's been a lot of debate, particularly in the oncocardiology literature, about what baseline investigations you should do prior to TKI therapy. And we have tried to make sense of this and be completely realistic about what we recommend is done. For instance, we don't recommend that you routinely do echocardiograms, for instance. And then as you're monitoring patients who are established on TKI therapy, what investigations you would do every 6 months, every 12 months, or as clinically indicated. Again, I would refer you to the manuscript because it's too much detail to take you through. One thing we have discussed in some detail is if your patient is intolerant of a particular drug, but actually responding very well, then you can seriously consider reducing the dose of the drug to see if you can minimize their side effects whilst maintaining their response. Obviously, you have to monitor them very carefully for that. But as I said before, there's a lot of debate about whether all these drugs were licensed at the right level, and increasingly we are messing around a little bit with the doses, but you do have to follow that up with rigorous PCR monitoring. So I probably talked for too long, so I just want to acknowledge the 38 other people on the panel, including Hemant, of course, and thank you very much for listening. Thank you.
So thank you very much, Jane. I think that was a fantastic talk. And all of us, including myself, gained some special insight into the not only the new ELN guidelines, but the state of art of managing CML patients today. So really, truly grateful to you. So if you can, please hang around for the next 15-20 minutes for some question answers and some during the panel discussion. But if you're busy, then we will quite understand. So let's quickly.
I'm okay for about 5 or 10 minutes, but then I have another meeting, so I'll nip off.
Sure. Okay. Great. Thank you. So let's not waste any more time. We are somehow we got a little late this time. Normally we finish on time, but let's jump quickly into the panel discussion, which is going to be moderated by Dr. Pankaj Malhotra. Pankaj, over to you. Your baby now.
Okay, thank you, sir, and thank you, the ISO, for associating me with this very, very important symposium. So let me share my slides. Okay, so most of the things have already been discussed. What I'm going to do is, the all the panelists who are with me, I'm going to take their opinion and asking them to share the experience on what they actually, practice. How do they practice management of CML in their clinic? So the faculty is already announced, and the panelists in this panel discussion are Dr. Jayachandran, Dr. Ghanshyam Biswas, Dr. Sachin Jain, Dr. Saurabh Bhave, and Dr. Hemant as the expert. So let me ask, since we are discussing about the CML in India, so let me ask my experts, and if they can share one by one the kind of a patients which they see in their clinic, the average age or the median age of their presentation, how many patients they see in chronic phase, accelerated phase, or a blast crisis, how many patients have extramedullary disease, and what is the socioeconomic status of these patients. So may I first ask Dr. Jayachandran if you are there? Okay, Dr.
Hello,
Saurabh.
sir. Yeah, I'm there,
Oh,
sir. So I was,
Jayachandran is there. Yeah, welcome,
yeah,
Dr.
I'm there. I was, thank you, sir. Thank you for inviting me. And that I'll just go into the question. So, age-wise, we see a slightly younger age population than in the West. And presentations-wise, it is most commonly we see a late CP, which is common. And nowadays, due to availability of a lot of the health checkups, we also see asymptomatic patients and extramedullary disease. Maybe we see most commonly associated with blast crisis, socioeconomic status. Basically, all socioeconomic status nowadays probably not in very uh, low because uh, over time, I think the socioeconomic status is not a major factor.
Okay, okay. Dr. Saurabh, Dr. Saurabh Bhave, are you there?
Am I audible, sir, now?
Yes, yes, you are audible now.
Yeah. So we also see patient, but little bit in the range of 20 to 40 years more. Second, we hardly see any APs or BZs. We have
Okay,
seen only two patients of extramedullary CML, one in the thigh and one in the back. The biopsy was not AP or BC, but it was CML at the extramedullary sites. Eventually, we lost follow-up to both of these patients. They were from Bhutan. And socioeconomic status across the board we see, from extremely rich to like very low socioeconomic status.
okay, great. So what I'm going to show is a table which is comparing the CML in high income countries versus low and middle income countries. And although, quite of this is discussed during the when Dr. Purvesh was talking to Dr. Hemant Malhotra, but I would like to, know your views on the same, about the difference of presentation of CML in the low middle income countries versus the high income countries. And I can first start with Dr. Jayachandran. How, I mean, do you see that this is the difference which you see in your clinic?
Yes, sir. Most of them are something which we see in this clinic. That's what I would say. Most of them are really depicted because first line treatment, I think that's the only thing which has changed because first line treatment nowadays, when we do have uh, generics of nilotinib and dasatinib, so a lot of people are being started on the second generation TKIs nowadays. That's the only thing which I would see, which is not depicted in this table because a lot of people have access to. Probably this is something like 5 to 8 years old.
Okay. Okay. All right. Dr. Saurabh, you in your practice,
So
do you
I
still
still
use
like
imatinib?
imatinib. I
Okay,
still like
great.
imatinib a lot. The side
Great.
effects of imatinib are visible to eyes, sir, in my understanding. Versus side
So
effects of dasatinib
I
are
too
not
like
visible to naked eye. They are
I too
difficult to
like
manage
imatinib, sir.
drugs.
I too like
Okay.
imatinib, sir. I just commented upon the table, sir. I too like
Okay.
imatinib. I commented upon
Okay.
what is different in this table.
So
Okay.
that
Okay.
is
Great.
one, sir. Second,
Okay.
monitoring, sometimes it's very difficult to have 3 monthly monitoring. TFR is not goal for most of my patients. Somehow they like to remain on imatinib, maybe at a lesser dose, and they continue for 10 years, 15 years. I don't have experience of more than 12 years of imatinib for a single patient. 20, 30
Okay.
years, I don't have that much experience. But lately, I am beginning to see side effects of imatinib like renal problems. And I don't know what to do with them. Sudden increase in creatinine. That's the trouble. I currently am a little bit perplexed what to do with such type of patients. Otherwise, this is whatever we are also seeing, sir.
Okay. Let me ask Dr. Hemant, sir. Sir, you have any expert comment? The kind of a discussion which we are having and the difference of CML patients in high income countries versus low and middle income countries.
Sir is about to get in as a panelist. If you can just
Dr. Hemant is in the panelist.
he's about to join in 1 minute or 1 or 2 minutes, sir.
Okay, and who else is the panelist? Sorry,
Dr. Sachin. Dr. Sachin is
Dr. Dr. Sachin. Dr. Sachin is he's running the lab or he's a clinician. I'm sorry,
I'm a hematopathologist, sir.
Okay, you are a hematopathologist. Okay, I'll come to maybe
Sir,
in the
Dr.
next
Hemant is
slide I
also
will
here.
discuss. Hmm?
Dr. Hemant is also here.
Okay, Dr. Hemant, we were discussing about the difference of CML in low middle income countries versus high income countries, and this was the table which I was showing. And we just had views from Dr. Jayachandran and Dr. Saurabh Bhave who agreed with this table. I would like to know your viewpoint on the same.
So, Pankaj, can you hear me? Am I audible?
Yes, sir, you are audible now.
Okay, so I think the basic difference is that we have more patients coming in with larger tumor load as compared to our Western contemporaries. We have younger patients, but I think the age factor is just a factor of our population dynamics. I don't think we have a different CML in our country. And the third thing is that we are diagnosing them late in the chronic phase, which a lot more genomic instability. And possibly that is the reason why we have slightly less hematological responses and molecular responses. And then again, we are resource constrained. Majority of patients or a significant number, they have trouble in organizing second generation TKIs because of economic issues, and they usually take government supply free imatinib. And monitoring is an issue again, primarily because of economic reasons. So we do have a different set of problems in our country. Over.
Right, sir. Thank you so much. So I've taken this table from one of the recently published paper. So let's go to the workup of CML patients, and let's first go to the CML specific workup. And make I can have opinion from the experts, including Dr. Sachin now, about one of the controversies, and or we see a lot of physicians are not doing bone marrow examination. So uh, let me ask Dr. Jayachandran and then Dr. Saurabh, do you do bone marrow aspiration and biopsy in your newly diagnosed patients of CML?
Yes, sir. Absolutely. I do bone marrow aspiration and biopsy in most of the patients. I never, sometimes I avoid a biopsy, but I never avoid a bone marrow aspiration. And in most of my patients, 95% of the patient, I do bone marrow aspiration BCR diagnostics. I do a bone marrow cytogenetics. I do a RQ-PCR for BCR ABL.
Dr. Saurabh?
So many of our patients are afraid of getting a bone marrow test done. They think bone marrow testing is a bone marrow transplant. So they run away. And then it's a problem. So I don't offer bone marrow aspiration biopsy to most of my patients. If we had starting doing bone marrows for CML in Tata, it would have been a major occupancy of the daycare beds and the load of the patients will be high. I theoretically completely agree that you should offer a bone marrow expression biopsy. The question is what I lose if I don't do a bone marrow. I think it is around 4 to 7% patients of ACA at diagnosis I may lose. But at diagnosis, ACA really don't carry a very significant risk as they carry a risk when they appear on treatment. And in so many years, I have hardly seen a patient in whom bone marrow was not done and the patient has not responded and straight away moved to a BC, not responded. So we are not doing. I do only RT-PCR at diagnosis, not RQ-PCR at diagnosis to for not a significant number. The cost of diagnosing a CML, if we do all these things, at least in Mumbai, where I am currently practicing, is nothing less than 50,000 rupees. And I think the imatinib is much cheaper, and giving imatinib at the appropriate dose is more important than whatever we do. So I don't do majority of the things.
Okay, let me ask now Dr. Sachin. Dr. Sachin, one of the question is that if you don't do the bone marrow examination, how many patients in accelerate phase or a blast cases you are going to miss? So I mean, if you are not doing a bone marrow examination, what is the percentage of patients where you think that this investigation uh, give you a view of the patient that whether patient is a high risk category and hence he requires a higher dose of imatinib or a second generation TKI, or we should consider something like consider at least for a bone marrow transplant. So what is your view? What is your experience on that?
Yeah, sir. In CML, basically, bone marrow biopsy, in fact, is more useful in these type of cases because you get to know the fibrosis. You get to know, as Dr. Jain has told, the cluster of megakaryocytes or at focal dense clusters of blast, which can characterize into the accelerated phase of the disease or the blast crisis of the disease. So, but in my practice, basically, we will see these type of cases almost 5 to 6% only, not more than that, which based on the biopsy you are getting these additional findings. Another thing, cytogenetics can be done from peripheral blood, but that information has to go to the lab because in that cases some culture stimulant has to added during the karyotyping from peripheral blood. Another thing is that diagnosis, I think, sir, it's a routine practice to do RQ-PCR, but I believe that has to be qualitative RT-PCR because the type of transcripts you will get to know only on the qualitative PCR. Because some of the RQ-PCR doesn't have that probe is not covering whole the fusion transcripts. So at follow-up, it will be a false negative. So in that cases, FISH BCR-ABL is more comprehensive to get to know the BCR-ABL positivity.
Thank you so much for this insight. Since we are running short of time, I would just go to I think your choice of initial therapy because that is the most important, questions which is there in the clinic. So, Dr. Jayachandran, what do you do? And maybe, what's your aim of treatment in the clinic when you see a newly diagnosed patient of CML?
First, save the patient, sir. I'm a conventional guy, so I save the patient. TFR is my last priority. Only for patients who are young females, wherein the patient is expected to brush your teeth, my brush. It's expected to get pregnant in some time. I would go for TFR as an thing.
So great.
So
That
my
is great.
choice is
So
imatinib.
yes. So
My choice is
so
imatinib, sir.
imatinib. Great. And let's say if you want to use dasatinib, do you use 50 mg or you use 100 mg?
So I use 50 mg, look for tolerance, and then escalate to 100 mg, sir.
Then escalate. Okay. Dr. Saurabh, your views?
So mostly I use imatinib at 400 mg dose. Dasatinib I start at 100, and if they tolerate 100, and I reduce to 50 if there is intolerance and the RQ-PCR is within the limits at whatever is the timelines. Nilotinib I have hardly used because of the fear of leukemia and diabetes and all those things. Bosutinib I have hardly used, so I don't know about bosutinib.
Okay. And generally, what's your aim of treatment? It is the overall survival or the TFR?
Even if it's a young lady who is married, have not yet had children or unmarried even, I somehow find it very difficult to achieve a TFR type in most of my patients. Forget about anything else. So first is overall survival for most of them. TFR I hardly try. But yes, if the patient is really keen, I try to give second generation TKI first, and then probably they may have for, but at least 5 years have to pass, and then only they can have a child. This is practically very tough in clinical practice. So mostly imatinib, and in few patient dasatinib. For elderly, I prefer to use imatinib, sir. If there are 55, 60 and above, they do well with imatinib rather than dasatinib and anything else.
Great. Thank you for your honest, opinion about these are the practical things, and I'm very happy that at least you are sharing the practical experience of managing the CML. Dr. Hemat Malhotra, sir, if you want to, what is your view as an expert on these choices? I mean, there is a trend now. People are using a lot of second generation TKI, but they are difficult to handle, a lot of side effects. So what is your view for the low middle income countries, or for majority of our patients who belong to low and middle income status? What is your view on the first choice of TKI?
So I think first thing is that I do a bone marrow aspiration and biopsy at diagnosis for all my patients, and if you counsel them properly, then I don't think there's any difficulty in having the patient on board and getting the test done. Then secondly, for my low risk patient, like low risk on SOCAL and low risk on ELTS, I'm happy to start imatinib. But for the intermediate risk ELTS and the high risk ELTS, I would prefer to start first line second generation TKI. I always start with 100 milligrams of dasatinib, and my drug of first choice, second generation TKI of first choice is dasatinib. And I do have the concept of TFR in the back of my mind for all my patients. So those are the little bit of differences. And I think this TFR thing is more of a generation thing. For you and me who've been treating CML for like 2 decades and 3 decades, we do think of TFR. For the younger generation who've been in practice for 5-10 years, they have fewer number of patients eligible for TFR, and limited experience for TFR. Over.
Right, sir. Thank you, sir, for your expert opinion. So these were already shown in Dr. Jane Purley's slides. So I think one of the question, I think, which again is important for the patients in low and middle income countries, and I feel that maybe a little bit different what is recommended in ELN or in the West versus in our country. Let's say if the patient is on imatinib and patient develops resistance, or patient develop intolerance, and the patient goes to the second generation TKI. That is one situation. And the second situation is patient is upfront started on a second generation TKI, and that patient develops resistance or intolerance. At what point of time do you suggest to do an HLA test? I'm not saying transplant, but at least the HLA test. In the ELN, they suggest once the patient is resistant to two TKIs, only then they suggest. So I want to know the viewpoint of our Indian experts. What do they feel of doing an HLA test? Do they agree with the ELN, or they feel that it should be done, HLA test should be done for transplant eligible patients after the first line TKI, it has become resistant? So, Dr. Jayachandra.
So I have the discussion on transplant 1 day after 2 lines failure. That time only I suggest doing HLA testing. So 2 lines of failure, I would see about going about this. 2 lines failure, so not intolerance. 2 lines
Okay, two
failure.
lines failure, you go for a transplant or you do an HLA test. I'm talking of doing an HLA test, just sending an HLA test, not doing a
I will
transplant.
have a I will have a yeah I will have a discussion about transplant at that point of time.
Right,
So that
right.
time I will suggest doing HLA testing
Okay, great.
after two
Dr.
lines failure.
Saurabh?
If it was AP at diagnosis, now this concept is not there, but if it was AP type at diagnosis, we do HLA, and if there is a sibling, we do HLA of the siblings also and keep the information ready. Now, if there is no sibling, we try to send the HLA to the registries in India and abroad and check where there is a mud donor available at that point in time. That's the information we keep ready. Second is if it is intolerance to treatment for 2 TKIs, and intolerance, the most common intolerance which we find is cytopenias. And that is one indication where they may require transplant, because cytopenias is the effect of all the TKIs, imatinib being the highest and ponatinib being the least. So if you have refractory cytopenia just not responding to standard, then probably in that HLA is important. Third is probably 315I mutation. I would do HLA, keep it ready, because I don't know how much the patient can afford ponatinib and for how long, because it is pretty, even the generic is not cheap. For first, we have to give 45 milligram, then one RQ-PCR, and then we can reduce to 30 or 15. So this is a whole lot. And of course, only if the patient is willing and affording for a transplant. If they are of low socioeconomic status, then it is very tough. Then we have to just manage with whatever we have and hope for the best. I have even used busulfan for few patients, sir, who just cannot tolerate anything. And they keep going maybe for 6 months, a year and a half, but eventually all of them succumb to the disease or the toxicity of the drugs.
Yes, thank you. Thank you, Dr. Saurabh. Dr. Hemant, sir, your views on doing an HLA test?
So I think if the patient is resistant to a second generation TKI, then I would think of an HLA test. But if the patient is resistant to imatinib, then I would start a second generation TKI. And if there is a suboptimal response to the second generation TKI, then I would do the HLA test.
Right, right. Okay, I think since we are running short of time, maybe I would go to the last slide. So, although we have discussed about the TFR, again, any last minute comment about the TFR from the experts, Dr. Jayachandran?
Sir, TFR is not easy. Needs a lot of discussion with the patient. You gotta sit down, understand everything with the patient. And I would prefer to keep the patient at least 5 years on TKI therapy, be it second generation or first generation. I will not jump in to the conclusion that second generation you can get it earlier. At least 5 to 7 years of treatment on TKI, and then a DMR of at least 2 to 3 years is what I would think about and have a discussion about, and then have about all the testings and other things. Then only I would go ahead, sir. Otherwise, I would not
Right.
routinely go ahead.
Thank you. Thank you, Dr. Saurabh. Do you do TFR or no TFR in your clinic?
I try to attend, but at least 5 years of any TKS.
Okay.
3 years is a bit tough, because we don't understand the patient by 3 years. It takes at least 5-6 years for us to understand how the patient will really behave. So minimum
Right.
5 years of any TKI and a good monitoring in the good lab. Sometimes they are fluctuating values, and then it's very tough in fluctuant BCR-ABL levels. Sometimes they 0.001, and then they become 0.01, then again 0.006. This is a bit difficult, a gray area. So I don't know what to do with this type of patient. But yes,
So
5 years, and then we can start discussing.
that is why there's a fluctuation. So we keep the levels of 0.1 and two values of more than 0.1 as a cutoff, sir. That's
We
always we
would
see. That always we see that fluctuations because of the laboratory issues.
Yes,
let me
deeper the
ask Dr.
better.
Sachin Jain. Dr. Sachin Jain is there. So, Dr. Sachin, what do you think? We all face this fluctuation, whether this is a lab error or this is a sample error, technical error. What do you suggest?
It's not a sample error, sir. It's a validations method between across the labs. However, international scale has been widely accepted in the main labs. Then also it's not that much harmonization and that much not validation, so that the that much 0.001 and 0.01 that levels differ lab to lab. So in that type of scenarios, I can suggest only is to follow the one lab only, and which is enable accredited. So rather than multiple labs.
Yeah, even in the same lab, sometimes, the fluctuations, we do see these
Yeah.
fluctuations. And I think the only message which is there to our colleagues is that don't change the things on one value. Look at the trend, which is
Yes.
important, and maybe, do it more frequent. Dr. Hemant sir, any last minute expert opinion on this? Because I think this is the last slide. Any comments, anything, any suggestion to the junior colleagues or the students who are listening to this panel discussion?
So I think I agree with my panelists, and I'm a strong believer that TFR should be considered in Indian patients also, particularly the young patients and the patients desiring pregnancy. And I also am a believer that our yardsticks for TFR should be a little more conservative as compared to the West. The ELN guidelines of reducing the frequency of BCR-able testing to once in every 6 to 8 weeks is very welcome. We now have a scientific backing, then we can do the testing a little less frequently. The lab has to be very good, and the clinician has to decide which lab he or she is going to use, and that has to be a really nice lab in which you have confidence and which can give you good reports. And sometimes the patients are hesitant to stop their TKI. So the best way forward for them, I feel, is that you offer them the Destiny type of protocol or the half TKI type of protocol, and they are much more comfortable. You reduce the TKI dose by half for 12 months. If the patient is still in deep molecular response, then you stop, and the patient also has a lot more confidence. So that is a trick which I do in quite a few of my patients, and for the patients who are frightened of stopping the TKI, that sometimes helps them in making the decision. And long-term toxicities of TKI, I'm really worried and concerned about long-term toxicities, and I think that should be kept in mind when you are counseling a patient, particularly a patient who is 20 or 30 or 40 years old and has another 30, 40 years to live. So toxicity anticipation, toxicity management are very important concerns. Over.
Right, sir. Thank you so much. With that, I thank all the panelists, and I hope so I have involved all the panelists, and back to the organizers. Thank you so much.
Thank you, sir. It was a lovely interaction, and what better platform we can have to have such great people speaking all together. Special thanks to Dr. Hemant for getting Dr. Jain here today. So today we were very lucky to reach around 300 people who attended our webinar. So I think it's a milestone in itself with so many meetings and webinars happening on a day-to-day basis. I would like to thank each and every faculty member, and above all, thank you, Dr. Hemant sir, for leading ISO from the front. And in your presidency, the first webinar was truly dedicated with the CML topic. So thanks once again. And the next announcement is that the next webinar is on artificial intelligence in oncology. And I think that will be a very interesting topic. So thank you, everyone, for your patient listening and your valuable time.
So thank you, Sumant, for organizing this so well, and our guest faculty, especially Dr. Jane Apperley. I think she's left now, and Dr. Pankaj, and our very learned panelists. We've had a very interesting discussion and a good start to the new session